off, just hit that end broadcast, but stop talking for about 10 seconds. Okay, so we're so excited to be here with Nicole Herndon. She's the SLP for UF Health Gainesville, and she will be talking about swallowing and ALS. So turn it over to you, Nicole.
Hey, thank you. Thanks to ALSA Florida chapter for inviting me to speak, and thank you for attending early on a Saturday morning. Let me just share my screen really quickly and then we'll get started. All right, so I'm going to be talking about swallowing and ALS today. And I just want to start off by doing an introduction into swallowing, and then I will talk further into what is considered dysphagia. Then I'll go into how we evaluate swallowing, particularly in my scope of practice as a speech-language pathologist for oropharyngeal dysphagia. And then I'll go into swallowing and symptom management for dysphagia and ALS. The swallowing, it involves about 50 paired muscles, and these are both voluntary and involuntary processes from the brain and the subcortical structure. So typically it's thought that the oral phase is more volitional, you have more control over that, whereas the pharyngeal phase is more involuntary. Once the process starts, your brain stem just kind of takes over for an automatic process. And swallowing is separated into 3 phases. So we have the oral phase, or the mouth, the pharyngeal phase, the throat, and the esophageal phase, the esophagus leading down into the stomach. And here's just a schematic about swallowing. So let's start with image 1 on the left. So you see what they call bolus of food, which is what this person masticated. Let's say it's peas. So they've chewed up the peas, they've formed it into a ball or a bolus of food, and it is on the back, mid-back of their tongue. In the middle image on number 2, they're swallowing that bolus of peas. So you can actually see the airway is in the front, and that airway is closed off. None of those peas are going down the wrong way. And then the peas are going through the pharynx or the throat and into the beginning of the esophagus. And then on image 3 here, you can see that that tail end of the bolus of peas is finishing entering the esophagus and presumably leading down into the stomach, and now the airway is open so someone can breathe. When we're talking about swallowing, we consider safety and efficiency. So safety, we're looking if there's any airway invasion, which we consider penetration or aspiration. So has any of the material entered the airway but stayed above or to the level of the vocal cords? That would be considered penetration. But if it goes below the vocal cords, it'd be considered aspiration, so more in the trachea area. And then we're also looking at swallow efficiency, so seeing if you can clear material from your mouth, through your throat, and into the esophagus without remaining residue. So here's just some definitions or parts of the swallow based off of, this is a modified Barium swallow study, which I'll go in. So right here is the base of the tongue, and here is the posterior pharyngeal wall. So those are our 2 boundaries, front and back in the pharynx, in your throat. Here is the soft palate. So during swallowing, the soft palate elevates against the back of the wall to try and prevent any material, food or liquid, from going up into the nasal cavity. Here's the epiglottis. So the epiglottis is a piece of cartilage that at rest forms a natural pocket, the vallecula. But when you swallow, that epiglottis inverts to help close off the entrance to the air. The laryngeal vestibule and the vocal cords are kind of your boundaries. So the laryngeal vestibule is what I call the entrance to your airway, leading down to your vocal cords. So if you remember on the prior slide, I was talking about how those vocal cords are a boundary between penetration and aspiration. So anything above the vocal cords or to the vocal cords is penetration. Anything below that into the trachea is considered aspiration. And in the back, the 2 bits in the back is your esophagus. While it's closed on this image because it's at rest, you can see the tight muscle there that's closed. We obviously don't want stomach contents coming up or air going into the stomach. And that's where we want all the food and liquid to go down into through the upper esophageal sphincter and into. So this is a modified barium swallow study. This is actually me swallowing different consistencies of barium contrast. So you can see some of the same structures that I just went over. So I'll go through this and I'll just play it through. It's pretty quick. So here's me swallowing thin liquids or a water consistency. Next is a little bit of a thicker consistency, nectar thick liquid. Here is a pudding consistency. And last, I chew some graham crackers, so a solid consistency. I'll have a little bit of pudding in there, so that's contrasted. So that's what a normal swallow looks like. When we're talking about abnormal swallowing or swallowing dysfunction, we call that dysphagia. So that could be problems in the oropharyngeal or esophageal stage of the swallow. And some consequences of dysphagia include malnutrition or dehydration, choking, aspiration pneumonia, taking longer to eat a meal, which then leads to some weight loss, and drooling. All of these things can lead to reduced quality of life, social embarrassment, and even mortality. It's really important that we assess for dysphagia in the disease of ALS. The way that we assess for that is with instrumental evaluations. They are considered the gold standard for assessing a swallowing function. So on the left, we're going to go over a modified barium swallow study. And this assesses the oro and pharyngeal swallow. And this is completed between a speech-language pathologist in conjunction with radiology. And you can see on the bottom left image, this is our setup at UF Health Excel. So we have a mobile C-arm unit, and you sit in the middle, and we take those X-ray videos while you swallow different consistencies of barium. You can see on the right picture there are just some examples of the Varibar barium products that we use. And I always tell patients they're a little chalky, but they're definitely tolerable. We just need that contrast so we can see it on X-ray, and it's important that we follow the consistency so that we can really see the broad spectrum of things that you may eat or drink during the day. On the right side, I'm going to talk about flexible endoscopic evaluation of swallowing, or what we call FEES. And this is usually done to assess pharyngeal swallow. And that's because the speech-language pathologist or ENT puts a camera through the nose and looks up above into the throat. So that's why they can only assess the pharyngeal swallow. And images are taken while you swallow real foods and liquids. So that is a benefit of doing a FEES, but it is blurred out kind of during the mid swallow because of just how structures come together against the light. So there's pros and cons to both of these, and it's worth talking with your team to see which one is best for you at that time. So here's just some examples of a modified barium swallow study in terms of safety and efficiency. So you can see on the left side is considered a normal swallow. So it's both safe and efficient, nothing's entering the airway. And I know it doesn't show it, but there's no material after the swallow. In the middle image, we have some impaired safety. So if you see where the arrow is pointing for A, you see materials entering that top part of the airway into that laryngeal vestibule, and that is considered penetration. And then for B, you see that that has now gone below the vocal cords and has been aspirated. And then lastly, on image 3, we have impaired swallow safety. So this person has swallowed, and you see pretty marked residue in that natural pocket leading down right above the esophagus. So now let's talk about some swallowing changes in ALS. So swallowing changes can occur in up to 85% of people with ALS. And it's more common in bulbar onset ALS than spinal onset, but it does occur in both diseases. Typically, bulbar onset, that's usually when speech and swallow are first impacted, and that is typically just going to be more severe earlier on than the spinal onset. Some best practice guidelines for persons with ALS who want to assess swallow function. We recommend a multidisciplinary team to identify and treat dysphagia. And these team members may include a speech-language pathologist, a dietitian, physicians such as ENT, gastroenterology, neuromuscular trained neurologists and their PCP, and an occupational therapist. And we recommend doing an instrumental evaluation about every 3 months to assess oropharyngeal swallow function. We know that with the disease, changes can happen very quickly, so we want to be adapting our recommendations fairly quickly as it changes. So let's discuss some common difficulties. So we're going to start with the oral phase. So liquid spilling out of the mouth, this can happen from weak lip closure, poor secretion management or drooling, fatigue with or difficulty chewing, nasal regurgitation, so that soft palate isn't elevating like it should and material is going up into the nasal cavity. Increased time moving material from the mouth to the throat, so that tongue kind of sealing and pushing thing back is less effective than it used to be. And oral residue, so that might be on the surface of the tongue, under the tongue, or even in the cheek pocket. In the pharyngeal phase of the swallow, we might see aspiration, so material going below the level of the vocal cords. And aspiration can occur silently, meaning it happens and there's no cough response. And this can happen this can happen in a majority of people with ALS. So this is why it's really crucial that we have an instrumental evaluation to assess. They may not cough, even if it does go down. Pharyngeal residue, so material sticking in the throat. Slow clearance of material through the esophagus or through the throat into the esophagus. And this may lead to multiple swallows, which can then lead to further fatigue. So if someone is swallowing 3, 4, 5 times for one bolus of food, that can lead to increased fatigue during mealtime. What can we do for these swallowing changes that occur in ALS? So we always recommend an instrumental evaluation because our recommendations are personalized to what we see there. And like I said, it can change. So we want to see you every 3 months, but here's some examples. So we might do compensatory strategies. These might include single or smaller sips, second swallows, or alternating bites and sips of food. We could also do some postural changes, but we like to trial those on instrumental evaluations to make sure it is indeed helpful. Sometimes they can actually be more harmful than they help you. We always recommend eating and drinking in an upright position. Gravity can change the flow of these materials, so we really don't want to make eating and drinking harder. Limiting distractions in a meal environment, and then frequent oral care. So I have an upcoming slide on this that I'll go into further detail. Some other safer swallowing strategies may include some diet modifications. So we are always considering the safest but least restrictive diet. We know how much changing someone's diet can impact quality of life. So this decision is not taken lightly. And I always say we provide recommendations to the patient and their family, and then they make a decision about what they would like to do. And these may include thickened liquids or changing the texture of food. So on the right, this is the International Dysphagia Diet Standardization Initiative, or IDSI framework. So this is commonly what some speech language pathologists will use to classify where someone is in their food and drink thickness or consistency. So cough function. Cough function can also be impacted in ALS. And Dr. Tabor Gray found that voluntary cough strength was reduced by 36% in individuals with ALS compared to healthy controls. An impaired cough or dysphagia can result in a slower, weaker cough, which if something goes into the airway, you have a less effective cough to try and eject that material. And that aspirated material could include, saliva or something that you're eating and drinking. And there's a predictive relationship between voluntary cough airflow and swallow safety. So it's really important that we consider cough function and assess cough function. So something that we can do to keep those respiratory muscles strong for cough and to try and keep swallowing improved or maintain function for as long as we can is respiratory muscle strength training. So Dr. Plowman found that expiratory muscle strength training, or EMST, improved maximum expiratory pressures, or MEPs, as well as swallowing efficiency and overall swallowing scores on her digest ratings. And she found that moderate intensity respiratory training using EMST is a safe and feasible option and well tolerated for early stage ALS patients. And Dr. Robinson also did a case study and found that EMST, or expiratory muscle, IMST, inspiratory muscle strength training, improved MEP and MIP pressures, as well as peak cough flow measures in that one patient. So respiratory muscle strength training is something that may be appropriate for you, but always contact your SLP regarding if it would be appropriate, and they can also help you with the training. So feeding tubes are another common topic that are discussed. So consider a feeding tube when someone with ALS starts to experience one of the following: dysphagia, forced vital capacity nearing 50% predicted, needs to be above that for safe placement of the feeding tube, and unintentional weight loss or dehydration. So there's certain things that you need to consider for a feeding tube, and those include risks and benefits of eating and drinking by mouth versus a feeding tube. And some people may choose to get a feeding tube because their forced vital capacity is nearing 50%, but they continue to eat everything by mouth. Some people will do a mixture of the two. So if they get fatigued after part of their meal, they might supplement with the feeding tube, and other people may eat and drink or may have nothing to eat and drink and may solely get their nutrition and hydration. And it's important to know the feeding tube may reduce but does not eliminate the risk of aspiration or aspiration pneumonia. And some people, make their decision, and that might change as the disease progresses, but it should always be documented the patient's wishes. Oral care. So oral care is really, really important. We need to get rid of that bacteria in the mouth. So if things do happen to go down the wrong way, less of that bacteria is attached to it. So regardless of dental or feeding status, oral care needs to be completed. Brushing the teeth, the tongue, the gums. We need that friction to get that bacteria off the surfaces. And if spitting out the toothpaste is really difficult, a portable suction device with the toothbrush can also be used to keep that oral care going. And routine dental appointments are also important. Sialorrhea or drooling is usually due to poor saliva management versus an overproduction of saliva. And treatment may include upright posture, wiping the mouth with a cloth, a portable suction device, or there's pharmacological options that you can talk about with your doctor, including medication or Botox. So to conclude, swallowing function commonly occurs in persons with ALS and worsens as the disease. Multidisciplinary team is crucial for the evaluation and management of dysphagia. Instrumental evaluations are recommended about every 3 months to assess or reassess oropharyngeal swallow function and adapt our recommendations. And treatment for oropharyngeal dysphagia and ALS may include compensatory strategies, diet modifications, EMST or RMST, oral care, and or feeding tube. And like I said, they're based on instrumental evaluation findings, the interdisciplinary team, the effect that it has on someone's quality of life, and the patient or family wishes. So these are my references. All right, I know I just have a few minutes for questions. You guys can also contact me via email. This screen and stop sharing. All right, I'm also going to be doing the learning lab from 10 to noon as well. If people have questions for that, I'll be in the swallowing learning lab. Right, on how a feeding tube could cause aspiration. Great question. So a feeding tube can also cause reflux, or maybe someone already has reflux, right? And reflux material can come up and be aspirated. Also, you're still having to manage saliva. So saliva could also continue to lead to aspiration, since management of saliva becomes harder. And if you have a feeding tube, do you still need a swallowing evaluation every 3 months? I think it depends. I think if you are choosing to still eat and drink by mouth, even if it's just for a little bit, sometimes it can be helpful to see if we have any different strategies for you, just to keep you as safe as possible or as efficient as possible, just to prevent any sort of problem from that. But I would definitely talk to your doctor and see what they think would be best. All right, so it looks like my time is up, so I'm going to stop the broadcast.